upper extremity blocks. The first speaker is again Dr. Balavenkat. He will speak on interscalene, subclavian, perivascular blocks. Dr. Balavenkat.
According to me, the satisfaction to become an excellent regional expert happens when you are able to give an upper limb block successfully. You give it, the hands fall, you declare yourself, I am the boss of regional anesthesia. So that's what happens with interscalene block and subclavian perivascular block. And I think as far as upper extremity block is concerned, a successful block is equal to the ability to identify the interscalene groove correctly. If you have done that, you have done your block. If you take this into consideration, I always say that extrapolation of facts, as far as upper extremity is concerned, if you are identifying your interscalene groove correctly, and the scalenus anticus medius, if you are able to palpate it correctly, if you don't have any gadgets, no PNS, no ultrasound, you are in a remote corner of this world practicing, where you have barely the local anesthetic solution, a needle and a syringe. Still, you can give a block with 100% success even without paresthesia technique. If you identify the groove correctly and push in your 23 hypodermic needle inside and inject a volume of about 30 ml inside, the block will take. I'm saying that if you are working in the most remote parts where you don't have access to anything, it works. It works because the interscalene groove is a small triangular groove here. If you just imagine what would be the volume of, if you palpate your interscalene groove, imagine what will be the volume if you take it as a small triangular box, it will be 30 ml. So if you fill this box with 30 ml of local anesthetic solution, you know the content inside is the nerve. And the drug has to reach the nerve and the block has to take. But only thing is it will take a longer time. But this is not, modern era. We need to progress with technology and we need to be a part of the progress, and we want to identify. So now the question is, identifying the interscalene groove is the problem, where you make a lot of mistakes all the time because there are two grooves very close to that. The groove that is very close to that which we make a mistake is this groove. So this is the scalenus anticus. This groove between the lateral border of the sternocleidomastoid and the scalenus anticus, this is the groove which many times we go in and we'll end up in a problem. And the next triangle is after this giving it lateral to the scalenus medius. Again, you will have not a good block. It would have taken but partial. Now let us see how to identify the interscalene groove rightly. So I'm doing it with a PNS technique. So now this is a young patient who has come for an upper extremity surgery. And now the patient's in the supine position. She's going to have a left side block. The head is turned towards the opposite side. I have a 50 millimeter Stimoplex needle in hand, which is connected to the Stimoplex DIG machine. Not sure whether it's DIG or HNS. And now if you see very nicely, if you see the two heads of sternocleidomastoid, you see the external jugular vein here, and that's the clavicle. Here is the positive electrode which is attached. This is actually, I think a HNS is there. Okay. So that's the positive electrode, and the negative electrode has been attached to the 50 millimeters needle. So that's the head of the humerus. Now, actually, I will probably have to, the audio can come? Okay. Now, anyhow, that's the sternal notch. So the number one point is identify the sternal notch. Go up and you see the thyroid cartilage there. Just below that is the cricoid. That corresponds to C6. So step number one, identify the sternal notch. Step number two, the cricoid. From the cricoid, just keep going laterally. When you cross the lateral border of the lateral head of the sternocleidomastoid, tell yourself that you have to go 1.5 centimeters more laterally. You will never make a mistake of going into the pseudo-anterior groove. So that's a very important point. And now you palpate. You will feel the apex of the scalene groove. Scalenus anticus and scalenus medius. Always use a single finger. Many people use 3 fingers, but I strongly advocate if you use a single finger, always it's very good only when you have 1 leader, not 3 leaders. So if 3 fingers, then you know, like, you're bound to make mistake. With 1 finger, you identify the groove, spend some time, put pressure, make sure that you're palpating it nicely, the anticus and medius. And once you have done that, if you see the external jugular vein always crosses it, it's a corollary that you're right in the apex of the groove. Then once you have reached there, I'm just going to showing it, palpating it again. And now you're going to introduce the needle. Actually, I think the emphasis has been, when I was doing it, was to show that you should never make a mistake and make sure that, tell your mind that you're palpating both. And this is a very labile skin, so you put a traction up so that you make the skin very taut. So because otherwise what happens when you pierce with the needle slips down into the posterior or anterior groove. So you use the same finger and put some traction to take it forward, and always tell yourself that the interscalene groove is, interscalene block is a very, very superficial block. The next thing that is very important is the entry of the needle. Just you set the current, now it's about 1.5 milliamps, and now after that you're going to pierce the skin, the subcutaneous tissue. And what is more important is when you use a peripheral nerve stimulator, the evoked motor response that you're going to get. This will ultimately decide whether you're in the right place or not. What is the best evoked motor response to get in an interscalene groove? Now that is the insertion. So the apex is felt just below the apex. Make 100% sure, skin made taut. Just below the apex of the interscalene groove, pierce the needle. So you should get a contraction of the pectoralis major, the deltoid, the biceps, or the triceps. Can you see the contractions? Yeah, so you should get at least 2 of the 3. You should get, so from 1.5 you slowly bring it down and you keep seeing for the contraction. You need to get a contraction even at about 0.4 milliamps as it was discussed. What are the negative things when do you go wrong? Suppose if you had introduced into that triangle, you will not see the movement of this limb, but you will see the contraction of the diaphragm. So tell yourself that you're anterior, take the needle out and go back into the posterior triangle. The next thing you can get at is the contraction of the shoulder girdle muscles, and then always it indicates that you're posterior. But when you actually stimulate the shoulder girdle muscles, you see a violent contraction happening to the upper limb. But the pectoralis major will never contract, the deltoid will never contract, the biceps will never contract, the triceps will never contract. So always look for this when you do a interscalene block. At 0.4 milliamps, when you didn't get a current, then you can inject the drug, and every 3 ml you need to aspirate and inject. So this is the next case, the subclavian perivascular block. I think I have a minute to do that. This is again identifying the interscalene groove. When you're using a PNS, identify the interscalene groove. In the interscalene block, you palpated the apex. But here, in the triangle, you go down the triangle and you go to the base of the triangle and palpate for the subclavian artery. And palpate for the subclavian artery in its entirety. And see, I'm palpating the subclavian artery. This is how I use a thumb for this. When you palpate the artery, you should palpate in its entirety. From the medial part of your thumb to the lateral part of the thumb, the whole thumb should feel the artery. So that the entire artery in the scalene groove is within your thumb. Only that much part of the artery is there actually in the base. It's equivalent to your thumb. So use your thumb and take it fully with you. Put lot of pressure on that. And now all that you need to do is, you have to imagine that you are going to go posterolateral to the artery. So insert the needle in the middle part of your thumb, and the direction of the needle is you direct it posterolateral to the artery. So only this thing has to be in your mind. No other direction that needs to be given. So I'm just piercing it. Only thing you're saying is it's posterolateral. So you see the contraction. So you should get the distribution of at least 2 of the 4 nerves. And if you know that, I'll finish in a second. So all that you need to remember is visually, if you want the musculocutaneous, it's the biceps, this will be the contraction. Okay. If it is the triceps, this will be the contraction, extensor response. And if it's your median nerve, this will be the response, brachioradialis, this will be the response. If it's your ulnar nerve, this will be the response. Okay, so it's very, very important that you clearly visualize which one you're stimulating, and whenever you see this, 2 of the 3, like what you saw here, you can